I would like to thank the organizers for giving me the opportunity to talk today on bridging quantitative MR imaging and artificial intelligence in oncology. I have no conflicts of interest to disclose with regard to the subject matter of this presentation. I acknowledge the support of my colleagues at Memorial, at RSNA, KIBA, and vendor scientists, and the support from NIH federal funding throughout. I've divided the talk in 4 subtopics. First will be personalized medicine and artificial intelligence in radiology, work in progress, followed by quantitative imaging biomarkers, Radiological Society of North America's perspective, and Memorial Sloan Kettering Cancer Center's implementation, academic industrial partnership, prototype technology testing and implementation in phantoms, and then examples in brain and head and neck region. Promise of artificial intelligence and MR imaging, algorithm and platforms available for clinical application in neuro-oncology specific. Artificial intelligence in medicine, new deep learning AI algorithms are showing promise in performing part of medical work, which until recently was thought only capable of being done by human physicians. Personalized medicine provides a specific therapy for an individual condition by stratifying disease status, selecting the proper medication, and tailoring dosages to that patient's specific need. A patient walks in, a lot of tissue sample, blood, saliva as needed are taken, and then the suitable treatment is planned. Personalized medicine in oncology is happening at MSKCC. Over the decades, we have been outstanding in vertical silos of genomics, proteomics, metabolomics, pathology, radiology, clinical annotation, and the list goes on. But right now, for the last 5-6 years, we have concentrated on the horizontal silos of integrating data and using computable data, connected databases, and intuitive visualization. We are learning from prior knowledge and predictive modeling, and then having treatment recommendation, capturing the new data, and the cycle goes on. Fully integrated effort to personalize treatment, so we move away from the concept of one size fits all. Enabling artificial intelligence in radiology, we know the words artificial intelligence, which covers machine learning, neural networks, how deep the neural networks are for deep learning, and we see this, it is at its peak right now, but we know from prior experience of imaging that it'll settle between the peak and the valleys, somewhere in between, like all imaging techniques have done. One of the benefits that I feel is that AI in radiology will help radiologists as these methods excel at automatically recognizing complex patterns in imaging data and providing quantitative rather than qualitative assessments of radiographic characteristics. I would like to put a little bit more focus on this slide because we're talking here about how I envision of the bridging of quantitative imaging with artificial intelligence. So deep learning is and will continue to change the trajectory of data science. There is a great opportunity if we accept discovery science. We must be careful with the choice of imaging metrics to be used. The demands on quantitative imaging are more subtle and indirect. Need better tools to mine deep learning networks. May need new techniques to implement features into practice. Before going into details, what is quantitative imaging? Quantitative imaging is the extraction of quantifiable features from medical images for the assessment of normal or the severity, degree of change of a disease, injury, or chronic condition. Quantitative imaging biomarkers are objective characteristics derived from an in vivo image. I'll just take two examples of QMRI. Apparent diffusion coefficient metric derived from diffusion-rated MRI. Volume transfer constant K drives derived from dynamic contrast enhanced MRI. Why are quantitative imaging biomarkers important? Because they have all evolution towards molecular personalized medicine requires quantitative test results. Similarly, evidence-based medicine, decision support tools, imaging endpoints, and clinical trial biomarkers require quantitative imaging. So what has RSNA and its group called Quantitative Imaging Biomarker Alliance, which I am a member of, and my colleagues here, what is the aim and the mission? I will just explain to you in a second. It was KIBA, Quantitative Imaging Biomarker Alliance, was initiated by Radiological Society of North America in 2007. Its perspective is very simple. One approach to reduce variability in radiology is to extract objective quantitative results from imaging studies. Its mission is to improve the value and practicality of quantitative imaging biomarkers by reducing variability across devices, sites, patients, and time. Industrialized imaging biomarkers. Here, I'll take you through the steps. How is the goal achieved? If a treating physician is waiting on a judgment to treat or to wait, and then a measurement is provided to him or her by imaging 7 millimeters plus minus 6 millimeters. That's not good. So we know as imaging scientists or radiologists that there are a lot of variants that can come from patient handling, acquisition protocol, reconstruction, segmentation, and the list goes on. What KIBA has done is written in detail documents called profiles, which give you details about acquisition parameters, reconstruction parameters, resolution, noise requirements, processing parameters, patient prep and operation, segmentation, calibration, and the list goes on. When all imaging components conform, then the metric can be evaluated with accuracy and robustness with, say, example, 7 millimeter plus minus 1 millimeter. And this will help the treating physician decide, or in this case, to wait. So what is the KIBA approach? It is for academic use, clinical trial use, and clinical use. What is the core step for RSNA KIBA is to select a biomarker which addresses gaps, impacts public health, translation in nature, good change to succeed in near term, leverages existing resources and technology, engages hardware, software, agent stakeholders, coordinate groundwork. This involves a lot of work, identifies significant sources of bias and variance, estimate achievable accuracy and precision, validate underlying assumption and mechanism, determine details to specify in the profile. These are very important. And in this ever-evolving, rapid-moving AI world, these things are to be considered. Draft the KIBA profile. The KIBA profiles provide claims, cross-sectional and longitudinal in clinical context. It specifies details necessary for robust implementation, take details they are implementable and testable, define conformance criteria for each actor in the imaging frame. Publish profile. You have to type as simple as www.rsna.kiba.profiles and you can access them for a while. You, as a site, should test conformance with KIBA profile specification, published, validated products and sites. So here I am just showing 6 different profiles which are available on this website. By just clicking on this URL, you can just write KIBA wiki rsna.org and profiles, and it will show up. Here I have worked very closely with the diffusion-rated MR imaging profile. And this is just representative 6. There are 20 plus profiles available with all the technical data from CT to lung volumetry to MRE to DCMRI and FDG. So there's a lot of wealth of information available, and we volunteer a lot of our time to bring this detailed information to users worldwide. In 2018, I wrote this review article about Quantitative Imaging Biomarker Alliance recommendations for improved precision of diffusion and perfusion derived biomarkers for multi-center oncology trials with my colleagues, ours and KIBA colleagues. And here, one thing, if I ask somebody how many diffusion perfusion papers are there for different organs in oncology, there'll be hundreds of thousands. But when we look for robust biomarkers, retest data, there's a lack of literature for retest reproducibility of the derived quantitative imaging biomarker. So we do emphasize that the method should be standardized, repeatability and reproducibility should be tested. And again, this is helpful for both quantitative imaging and when we are looking forward for artificial intelligence. Academic industrial partnership is again key because in MRI, we know it is ever evolving technology. We move up to different field strengths from 0.5 Tesla, 3 Tesla, 7 Tesla and on. So all these technologies have to be tested, and new acquisition protocols, new acquisition sequences have to be tested in phantoms, patient volunteers, and then patients. So here is some work that was done by us within a multi-center international setting with our colleagues. And what we used was the ISMR-NIST Phantom for quantitative analysis of MR fingerprinting. So this is a new technique, MR fingerprinting, which gives you multiple contrasts in a single acquisition. And it was tested in 13 days longitudinally at both 1.5 Tesla and 3 Tesla. As you can appreciate here, there are errors, T1 errors, T2 errors, fiducial markers, and this was recently published by us in 2021. So just going about the sequence, magnetic resonance fingerprinting is designed to provide multiple quantitative parametric maps with a single acquisition. In this sequence that we have prototyped, it's a steady state pre-precision MR acquisition with a list of TR and FA and fixed DE, resulting in a number of highly undersampled images. And what we get here, same acquisition parameters were used to generate the dictionary with the block equation, signal evolution curves obtained from the scanner acquired images over time were compared to the dictionary generated curves using pattern matching. And completely matched or closely matched values were utilized to obtain the desired parametric maps. And this is just a workflow to show here to reemphasize that data is acquired as well as simulated. The data is matched with the dictionaries, and then the T1, T2 photon density maps can be generated and others, different contrasts. We did a lot of heavy weightlifting to do this in multi-center setting, and we will show here the values of all the protein spheres for T1, T2, both at 3 Tesla, 1.5 Tesla, and we used compared them with the gold standard provided by the vendor. And what we see here is the arrays right here, and we did a very exhaustive repeatability and reproducibility, which is published in the journal Medical Physics 2021. And here, just to bring your attention to few wires that you can appreciate the repeatability, which is given by the coefficient of variation in percentage, is that for T1, it is less than 5, and it is also agreeable for T2, and also the reproducibility is given for different centers, and this also can be appreciated that it is less than 7%. So this is very agreeable with the literature, and this was an exhaustive work done at our lab and our collaborating institutes. And yes, again, the steps that we just said, we tested it in the phantoms, tested it in the patient, and this is the T1, T2 photon density. These maps can be generated within a single acquisition. So for protocols for rapid acquisition in the brain, this will be very helpful in the future. Similarly, the vendor also has Another acquisition protocol with multiple contrast and single acquisition, magnetic resonance image compilation, which is MAGIC. And here what is happening is that data is collected and then the images are synthetically generated for the different contrasts. So it differs from magnetic resonance fingerprinting. So again, this is the data acquired by our group and showing the results from MAGIC. And we are also comparing results from MAGIC T1, T2 relaxometry measures between the two sequences. They are different, but we are comparing the results for the white matter, gray matter, T1 and T2 values obtained. So moving to head and neck, we have done this MAGIC for head and neck as well. And we can appreciate that within less than 5 minutes, you can generate multiple contrasts from a single acquisition, and then you can compare it, the resolution with standard clinical sequences as shown in the left panel. We have been working over the decades with diffusion-rated imaging, and when in 2008, reduced field of view was published, this was very exciting because as long as we are acquiring echoplanar imaging, there will be distortion. So focus enables high resolution diffusion with less distortion than regular single shot PPI and avoids artifactual regions from the field of view. 2D RF pulses minimize excitation field of view in phasing co-direction, and narrow band 180 degrees refocuses only on resonance water frequencies reliable fat suppression. And this was primarily developed first for the spine, but then it found advantage in other organs as well. And we had tested and published it for thyroid in 2015. Here on the right panel is the full field of view diffusion-rated imaging. On the left panel is the reduced field of view diffusion-rated image, and we can appreciate the reduction in artifact. And still talking about diffusion, recently multiplex sensitivity encoding muse acquisitions have been carried out by our group. And here phase segmented multi-shot acquisition. This is different from the single shot acquisition. And as here it can be shown, this was collected over phase segmented over 4 shots. And we tested this in head and neck. So multiplex sensitivity encoding, phase segmented multi-shot acquisition reduces distortion and increases resolution by splitting the echo train into multiple shots. This is the panel, this is the neck nodal metastasis. The yellow arrow is pointing towards single shot PPI, muse without distortion corrected. And we also, the vendor scientists, developed reverse polarity gradient distortion correction. And we have shown here that it is further improved. And on top is the B value at 100 seconds per millimeter square, and below panel is the ABC values. And we can see that there is improvement in the measurement for ADC when used with DCE is used. So now moving on for algorithms for data analysis. In our lab, over continuous funding for close to 2 decades, we have from NIH, the principle, we have developed MRI Campbell, which is the quantitative analysis, multi-parametric evolution routines, and for the last decade, we have focused working on it. The principal functionality of MRI Campbell is to calculate parametric maps for multi-B-value diffusion-rated imaging and dynamic contrast enhanced MRI. The software is featured in our MSKCC lab's recent publications, and initial performance of MRI Campbell diffusion routines were tested using the digital reference object produced by our colleagues and has been submitted to the MRI NCI Quantitative Imaging Network group for review. The software has also been used to participate in the multi-B-value challenge for prostate by one of our colleagues. And similarly for DC MRI, the TOPS models were tested using the DCE DRO provided by colleagues, and the results were checked with the reference values provided by the DRO developers. The results were consistent. And this software, MRI Campbell, is approved by NCI Quantitative Imaging Network for technical benchmark level 4 in 2019. And recently we have submitted this for approval for clinical trials, as it has been included in clinical trials as in memorials and outside. So what does it do? MRI Campbell, as you can see, this is just a snapshot of the features. It's a platform which evaluates T1 maps, gives you T2 mapping, and all the different routines for diffusion and perfusion. For diffusion, it is the mono-exponential metrics are ADC. For kurtosis imaging, the metrics are the the apparent diffusion and the kurtosis diffusion coefficient, and IVIM, which has perfusion fraction, true diffusion, and pseudo diffusion, and non-Gaussian. This was developed by our group, and where we added kurtosis to IVIM and called it non-Gaussian IVIM. Similarly, for DC MRI, the different routines or algorithms are the standard TOFS model, extended TOFS model, shutter speed model, and the PATLAB. And this is this is open for sharing with appropriate material transfer agreements with Memorial Sloan Kettering Cancer Center. So this is just showing few representative metrics: ADC, which is a surrogate for cellularity; kurtosis, which is a surrogate for microstructure; kurtosis K-trans, which is a surrogate for permeability perfusion; and tau I, which is the mean intracellular water lifetime, and gives these all metrics give characterize tumor physiology and hence are important for clinical endpoints. So showing some example how we use them in clinical practice at Memorial. Head and neck squamous cell carcinoma was traditionally associated with behavioral risks such as smoking and alcohol. Human papillomavirus infection has emerged as a novel etiological agent for oropharyngeal carcinomas. HPV negative tumors continue to have poor prognosis despite treatment intensification, while HPV-related tumors are associated with markedly improved outcomes and are now accepted as a distinct biological entity. So the big question is to identify patients with tumors exquisitely responsive to therapy would felicitate the next generation of clinical trials in HNSCC. And again, we always do what we say. We did the repeatability of the quantitative imaging metrics. This is in diffusion metrics in phantoms, both in head and neck and thyroid cancer, and the preliminary data was published in 2019. Here is showing the fit of the data using the non-Gaussian IVIM, and the red is the mono-exponential modeling. And here we can appreciate the metrics. This is the ROI, the neck nodal metastasis, the ADC metric, the true diffusion, and kurtosis. And this is the panel showing scan 1, scan 2. That is the repeatability of the measure for these different metrics. And within subject coefficient of variation is commonly used metric for quick precision. And here we have published that ABCD, D star, K, and F mean within coefficient variation was 2.38, 3.55, 3.888, and 9.92 respectively for these metrics. Precision is a key performance characteristic of QIBs, and we know that ADC is commonly used metric for surrogate for tumor cellularity, and here we can appreciate that the within coefficient variation is less than 3, and it can be used in clinical trials. So same measures were used, and intravoxel infrared diffusion weighted MRI was tested for chemoradiation to characterize and monitor tumor response in HNSCC and in our group. And the main finding was that the mean increase in the delta true diffusion between pre-treatment and week 3 for the complete response group was significantly higher than the non-CR group, non-complete response group. Apparent diffusion coefficient from the mono-exponential modeling and D from the true diffusion from the IVIM modeling showed an increased trend at each intra-treatment week when compared with pre-treatment in complete response group. This was patients received 70 gray radiation, and hierarchical clustering demonstrated the existence of clusters in HPV positive patients. So this is just demonstrating a representative patient here, ABC And D histograms are shown here, and this is the neck nodal disease, and this is the ADC metric pre-treatment, D true diffusion metric pre-treatment, and on the right you can appreciate the red histogram bars for pre-treatment and the green for intra-treatment week 3. We did it every week, 1, 2, 3, 4, 5, to measure response, weekly response. And here we can see there's a shift in the histogram values of the ADC toward the right on higher values. And this in head and neck, as well as in other cancers, has shown to be a marker of complete response. And on clinical evaluation, this patient had complete response. So I just mentioned a minute ago, heat map was generated from hierarchical clustering, and here we can appreciate top big cluster consists of 13 patients. 3 of 4 HPV negative patients are clustered together, and all CRs, non-CRs, belong to the same cluster. That means they are subtypes in the HPV. So we can see all this is clubbed together in HPV positive, the negative as well, and the non-CRs. And here are also another subtype of HPV positive. What it is telling us that when we put these metrics and to hierarchical clustering, we can identify that there are 2 types of HPV positive subtypes. And this work was very well, went very well with the in vivo cell, in the cell line work, which was published by Rickman, Campbell, and Park, where HPV positive cell lines behave differently, and one behaves some similarly to HPV negatives. So what is it telling us? What is the story? HPV positive disease. Is it all the same? The answer is no. So this was very remarkable for us to know that as we were working for in vivo studies, the cell line studies showed the same pattern, that all HPV positive are not the same. This study on dose de-escalation in HPV positive oropharyngeal cancer is led by a radiation oncologist. And here we are, she has led this trial which triages patient on F-myso hypoxia tracer and negative at baseline for early response are RT to P30 gray with cisplatinum, and then 4 months follow-up, and a lot of pathological imaging is performed on a weekly basis. And for the patients who are F-myso positive, get the standard dose of radiation. And a lot of whole exome studies are being carried out to understand the tumor. And so they are trying to understand the 4 R's of radiobiology: reoxygenation, repair, repopulation, and redistribution. So this is just a photograph of the mouth of the patient on the left panel who received 30 gray, and on the right from a patient who received 70 gray. And I think everybody can see that the patient who received 30 gray had less toxicity. At 30 gray, no anticipation of late complications such as urostomia, dysphagia, and osteoradionecrosis. So this is very important. If the outcome can be the same, then the patients are eligible for dose de-escalation, and especially when they are showing hypoxia negative result and have MR imaging weekly. So this is precision radiotherapy and longitudinal imaging. When I started my talk, I talked about precision medicine, and this is an example showing at Memorial how it is happening as we speak today. And this has also come out published in JNCI this area in 2021. It is called the 30 Rock Trial Reduction in Radiation for Oropharyngeal Cancer. And as you can see, there is MR imaging, FDG PET, both F-myso, FDG imaging, as well as a lot of pathology information from these preliminary data that was collected on these 19 patients. Again, this is the pathological response in de-escalated patients. Majority of the patients did do very well, were complete responders. And here you can appreciate the pre-treatment hypoxia, the intra-treatment hypoxia measurement, tumor permeability as measured by MRI, intra-treatment microstructural changes as measured by MRI, and by kurtosis, tumor permeability by K-trans, and all. And here, this is a representative pre-treatment and intra-treatment with 3 MR images with MR parametric maps overlaid on the neck nodal disease. Here again, we can appreciate the different metrics, A, B, C, D, G star, F, K, and this is all data from the pre-treatment. This is all the data from the week 3, and that was shown in this paper in JNCI. And we can see that there's a big change in the patient metric maps showing and going to higher values. If I just comment on the ADC, apparent diffusion coefficient, a marker for cellularity, that this is a patient who did receive complete response. Now going back to where we started again, bridging QI in AI. This slide is a bit dense, but I do want to go over each point because again, this is very, very important because in artificial intelligence is moving very fast, and it is the responsibility of each group to take these points seriously and work on it. To develop a reliable AI algorithm, the steps include reliable data engineering with reference standards and good quality data annotation. A training data set that matches the intended use case, queuing hyperparameters on a data set depending on the training data set, and using external validation data set to evaluate the model performance. The AI method should be robust to variability in MRI position parameters, settings, and clinical condition, and should be trained with a heterogeneous data set. So this is how, go at the very beginning, I mentioned all the different requisites, how RSNA KIBA works very hard to do those profiles where all these technical elements are mentioned in great detail and how to use that open source resource. And QAI should aid AI. Quantitative imaging should aid AI, artificial intelligence, with implementation of optimum methods for standardization, including harmonization of the input MR images and additional pre-processing steps. We have to be responsible for these things to have robust AI algorithms. It would be challenging for multi-vendor data, especially when the inputs are multimodal. AI model used for clinical endpoint should be further fine-tuned at each institution with their data, and each updates need to be monitored for the repeatability and reproducibility as they may change with time. In MRI, MR imaging, people are familiar that things change. The field strength, as I mentioned earlier, can change. Design of organ-specific coils. We have different types of coils now. Gradients are ever evolving, and we will need to perform finer adjustments to the QI measurements being used in the AI pipeline. Quality measurement assessment methods of AI at each institution should be established. And what is the platform for this? I'm not going into much detail, but I'll just point you towards one such platform called Deep Neuro, and open source learning toolbox for neuroimaging. It's a Python-based deep learning framework. This framework can be used to design deep learning pipelines that can load and pre-process data, design and train various neural network architectures, and evaluate and visualize results of trained networks on evaluation data, a way of reproducibly packaging data, pre and post-processing functions common in the neuroimaging community, which facilitates consistent performance of networks across variables, users, institutions, and scanners. Going on some examples on neuro-oncological MR imaging for clinical application. This can be used for clinical diagnostics, imaging-based biomarkers, and response assessment. Just, I would again draw your attention to this elegant review article where they have mentioned that artificial intelligence has the potential to improve efficiency and accuracy in neuroradiology. AI tools are starting to be validated for tasks such as workflow optimization, segmentation, and precision education for a variety of brain diseases. Future AI may integrate imaging data with additional diagnostic data from the medical record. Again, another review article which has elegantly mentioned One of the overarching goals of AI-based research in neuro-oncology imaging is to better understand the complex manifestations of heterogeneous central nervous system neoplasms in hopes of improving patient outcomes. So this is a very detailed word processing workflow, but just to draw your attention that there are so many ways that AI will help in the future, from MRI acquisition to general image processing, segmentation, feature set synthesis, predictive modeling, machine learning, and development of newer models. And this is where we feel that a lot of work has to be done and can be achieved. One second, I will just go back to my slides here. Oncology imaging and clinical management workflow can be useful for both precision diagnostic and precision therapeutics, because initial lesion detection and analysis system would generate a probabilistic differentiation of lesions seen on patients' initial brain MR images, precision diagnostic. It would also recommend additional useful imaging examination laboratory tests or tissue sampling. Glioma-specific modules could be personalized predictions of molecular markers, survival, and treatment responses, thereby recommending optimal treatment plans, which could be continuously updated on the basis of follow-up imaging. This is original work carried out by this group. Quantitative machine learning analysis of clinically acquired multiparametric MR imaging can identify subvisual imaging characteristics to provide robust non-invasive imaging signatures that can distinguish pre-progression and from pseudo-progression. Just to see this workflow on the top, you can see all the data from the MR imaging, the imaging characteristic, extracted features. On the bottom row, you can see data from pathology and pathology scores, which are again fed into the machine learning classifiers. So in this result was very exciting because they show that quantitative MPMRI analysis via machine learning reveals distinctive non-invasive signatures of TB versus pseudo-progression after treatment of glioblastoma. Patients who demonstrated true progression on neuropathology are significantly different from those of pseudo-progression, showing imaging features reflecting higher angiogenesis, higher cellularity, and lower water concentration. Integration of the proposed method into clinical studies can be performed using the freely available cancer imaging phenomics toolkit, for example. And I would like to summarize this talk by going to all major points. Personalized medicine provides a specific therapy for an individual patient. Artificial intelligence is being developed and tested in radiology for clinical application. Deep learning methods are inspired by human brains and how it works. That's why it's called neural networks. It can be very helpful in clinically centered imaging tools and global application. Quantitative imaging biomarkers are a prerequisite for personalized medicine feasibility study and reveal and identify sources of measurement error or variation underlying clinical environment, which is influenced by many factors such as care, reliability, protocol consistency, patient steadiness, and among others. A strong academic industrial collaboration is needed to ensure that global imaging in cancer research can happen. AI is showing promise in improving clinical workflow and towards clinical endpoints in neuro-oncology. It is still work in progress, and attention needs to be paid to dataset engineering, robust architectures, and most important, patient privacy. Thank you for your attention.